Hello and welcome to week 6. We're halfway through. I hope you are doing well this week, wherever you are listening to this. Let me just move that a bit. So this week we're going to take up COVID-19. We've been obviously, since everyone globally has been living this for the last whatever it is, 7, maybe going into 8 months. Obviously, we're weaving it throughout the course. The course very much has been taking COVID up the entire time. But today I wanted to do kind of a focused week on it and then really look at the hyper locals. So really focus on COVID-19 and where and how it's being lived in the area where York University sits. So in the University Heights is the neighborhood where York University is situated. So we'll take that up today. So of course, as always, starting with a land acknowledgement. So York University acknowledges its presence on the traditional territory of many Indigenous nations. The area known as Tekaronto has been caretaken by the Anishinaabeg Nation, the Haudenosaunee Confederacy, the Huron-Wendat, and the Métis. It is now home to many Indigenous peoples. We acknowledge the current treaty holders, the Mississaugas of the Credit First Nation. This territory is subject of the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. I'll go back. So kind of where I want us to think about moving this land acknowledgement today is really thinking about COVID in relationship to land and people who occupy land. And so looking at the ways that COVID is lived differently based on where it is. And so if we think about the ways that Indigenous peoples are living COVID at the beginning, we heard a lot about out west in terms of the transatlantic pipeline and how Indigenous communities would have people working on the pipeline, transient workers moving through their territories, which clearly we know is something that can bring COVID into spaces where COVID wasn't. So Indigenous folks saying, listen, this is our sovereign territory and we want to protect ourselves, and what that looks like when people are moving in and out on large scale transnational energy projects. So thinking really about land in relation to COVID and ways that communities are able to protect themselves, but then because of these larger state-run projects, these larger sort of pieces around transnational capitalism are unable to. So we saw a bit of that at the beginning of COVID, and I'll post a link in the week's folder that you can read a little bit sort of more about ways Indigenous peoples in Canada have been living with COVID. So today I really want to take up, I got this image from the Health Common Solutions Lab, and I really want us to take this up. So kind of thinking about COVID-19 in relationship with social determinants of health. So I want you to first start by kind of mapping your own experience of COVID. So, you've started to do this kind of reflective work with your critical reflection paper. So really thinking about going through these different areas: food security, challenges going to the grocery store. For example, single parent families with no childcare, how you navigate doing that. Seniors living alone, what that looks like. Ability to afford food, so fixed income seniors, families on ODSP. So what does that look like? So go through each of the areas and kind of think about how COVID has shaped that determinant for you. And then push that a bit further to think about ways that you have been able to insulate yourself, protect yourself from COVID, and then ways you haven't. So how those social determinants really determine your risk to getting COVID or not, your risk of your community in getting COVID or not, what transmission rates look like because of these social determinants. So these, of course, it's not exhaustive. Another thing I wanted to do is kind of think about that in terms of, are there other pieces you would add? Is there something that's really missing here because of the intimate way that COVID has been lived out in your community, in your family, in your own life? So maybe thinking about what you would add, maybe thinking about intersections that you would add, how you would deepen this. So we have these categories, but again, based on your own lived experience, what would you add? What's missing here? So I think this week, I really want to think about this idea that we see this through COVID, we've really been able to see how a hyper focus on accessing frontline care in a hospital is not what determines our health. So that's, of course, something we're exploring throughout this course, but I want us to think about that in the context of COVID. So we'll do that thinking about COVID lived in the area around York University. But I want us really to think about that. How do all of these things actually determine our risk factor for COVID or not? Ways we can protect ourselves from getting COVID or not. So basically thinking about all these different areas: housing, job and income security, social isolation, transportation, culture and language, access to healthcare, environment and safety. So housing, of course, determines ways we can or cannot isolate safely. What your working conditions look like, if you're able to take time off or not, how you're able to be safe while you're at work, how many jobs you have to work, which puts you at different levels of exposure. How you get to work, how safe is that? Do you have more level of exposure on ways that you have to take transit or not take transit? About where you live and what school maybe your children go to. So the data looks very different in terms of neighborhood on how much, what the risk is for children and COVID based on neighborhood. About ableism and how that intersects. That's a piece that's missing here, right? So we're going to take that up in depth when we welcome a guest lecture on the week of disability justice. But that, there's many ways that ableism shapes your access to COVID and what your care could look like if you get COVID or if you've had COVID. About racism and how it intersects. That's another piece that's missing here, right? So thinking about how racism intersects with all of these, and we're going to kind of do that work today. It really struck me in many of your critical reflection papers that I looked at about ways that racism intersected with ways that you felt safe or fear in terms of distrusting the healthcare system. So that made me think a lot about, we know that, receiving attention, care early on makes a difference in terms of can make a difference in terms of severity of COVID. So if there is a lot of mistrust, if there's fear about ways that you will be received in the healthcare system, folks might wait longer. Yeah, I think we'll just kind of start and go through, but I want you to really first pause the lecture and start mapping out your own map. What does this experience look like? And then what can you think about in terms of ways that that has either put you at more risk or put you at less risk and really protected you over this, past 8 months in terms of COVID. So coming back, what links did you make between the social determinants of health in your own life and ways you have been impacted by COVID-19? Were there clear patterns there for you? Were you able to see that, no, I don't have many folks in my life that have either contracted COVID or died from COVID? And that, is determined by all of these things that I've gone around that wheel, which probably corresponds with the wheel of power exercise we did. So I want you just, to think about those links. If we were in a big room together, we would bring those links together and kind of think about that in community. We're not able to right now. Just thinking about how those wheels all do specific things. ways you've been able to access privilege during COVID or not access privilege during COVID is going to determine how affected your life has been sort of directly by COVID. So I want to start by saying there's lots of interesting data that has come out with COVID, right? So there's all kinds of places you can access this data. Maybe in the follow-up prompt area, I'll put some good Twitter handles of folks to follow. So some doctors, epidemiologists that are tracking in really interesting ways and putting out really interesting maps. There's some folks who are tracking by school transmission, community transmission, what that looks like. And they're kind of easy maps to look at, and how where we're seeing community transmission and where we're not seeing community transmission. So Toronto, now City of Toronto is collecting the data and showing and kind of mapping where cases look in terms of neighborhood. So I just pulled this. This is from Toronto Public Health. The Toronto Star did a big piece, but it's behind a paywall. So the Toronto .ca link that I have up here is a better one to go to because it's not behind a paywall. So you can click and you can find out, you know, where you live in Toronto, if you are in Toronto. If you're not in Toronto and not familiar with it, then use the neighborhood of University Heights, because you'll be able to kind of look at, you know, if you were here right now, what that would look like in terms of the neighborhood you would most likely be living if you were coming to live in student housing. So as I said, here's a map. We can see the darker it gets, that's the higher amount of COVID cases per 100,000 residents. So you can see where the kind of hotspots are. And where the biggest hotspot is in that top left-hand corner, which is the northwest area of Toronto, which is where York sits. So North York and kind of Etobicoke area. So York University sits on one of the highest hotspots. If you go to the link here, toronto.ca link, you can type in University Heights and see what that looks like today. We've had some of the highest cases throughout. The York University Heights area has not seen a dip. We've just seen progression of cases going up. There hasn't been that kind of reprieve that the rest of the city had in the middle of the summer when we went down to stage 2 and folks were kind of like, okay, you know, things are feeling okay. I live in the York University Heights area, and, you know, folks were still living this the same throughout, right? So, and we'll go through what that looks like as we move through the slides, but I want you to jump onto that link and find out where you live, what cases look like in your area, and then what this top North York sort of quadrant looks like in terms of cases. And then we're going to go through what that actually looks like. So I brought up Dr. Bouzoury's work before. He's a physician and co-lead for the Toronto region's COVID-19 homelessness and shelter response. He's also the executive director of population health and social medicine for UHN. And you can follow him on Twitter. I put up his Twitter handle before, but he's amazing, just this really rad doctor and prof who's working on this on the front lines, and really talking about this idea that I've tried to weave through the course, which is we've never been in this all together. So we have lots of public health messaging. We're all in this together. We can stay well together. We will get through this together. And when we look at the data and where COVID is actually living, we aren't all in this together. Many of us are protected in very specific ways, and others are not protected in very specific ways. So I threw up the link to this article. It's an interview with Dr. Bouzoury on the Canadian Healthcare Network. And he talks about a lot of the things we're bringing up today. So one of the things I wanted to highlight was the fact that in your critical reflection papers, the vast majority of you were very taken aback and surprised that we do not collect race-based data in a country with such diversity in our population, right? Especially say in a place like Toronto, where we are highly, highly diverse. Why are we not collecting race-based data? So COVID was the kind of breaking point, the push to do that. So one of your readings for today is to actually go through that data. So you can go through the Toronto the Ontario Public Health data and look at that data disaggregated for race. What does that look like? And so, the big stat that you read in the CBC article, which was on your reading list for today, was that 83% of COVID cases are in racialized communities. So we know that the vast, vast majority of folks who have got COVID are in racialized communities. And there's very strong links with poverty. And we will go through these kind of determinants of what that looks like. But that Dr. Bouzary here tells us that the early data and the data, of course, now tell us that there's a very clear association with poverty. And that's what the social determinants are really telling us about, right? Your social determinants to health are very closely linked to the ways that poverty intersects in your life. So he says here, quote, as a country where we are well and far behind other jurisdictions in collecting socio-demographic data, race-based data. And that was something that you were very surprised at. Why aren't we doing that? So we have begun to do that with COVID, and there's calls from grassroots organizations, there's calls from community health clinics in the areas where COVID is hardest hit, in Toronto, saying, listen, we need to have very different strategy based on neighborhood. We need to allocate resource differently based on neighborhood, because COVID is not being lived across the board in the same way. So we cannot respond to it across the board in the same way. So we'll go through that today. So I put the link there if you want to read the entire interview. It's a really great interview. So let's think about how, let's use one of the kind of tools that we've taken up from last week, intersectionality. So what does this look like if we use intersectionality to understand this better? So we're going to look at in depth the community around York University, which we know has many intersections with poverty, with race, and then we're going to look in kind of each of these areas and see what that looks like. So keeping that, this idea of intersectionality in focus, that we need to know how this is being lived at different intersections, not an overall disaggregated picture of COVID. That's not telling us much, and that's not telling us where we need to intervene, where we need to respond, what kind of policies we need to put into place. I think big example that comes to mind at the beginning was one of these kind of COVID responses in terms of policy was having a kind of standardized number that every person over the age of 65 received. So to say, elderly folks are living COVID in a, the death rate is higher for elderly folks, so let's throw some money at it. And so they did, instead of saying, sort of, that could look different based on where you live, based on different intersections. It was just one universal amount that everyone received. And is that the way to actually sort of get at who's living COVID and where we need to spend resources? And of course, that was early on. That we didn't have the data yet to back up these kinds of policies and decisions, but we do have that data now. And so how can we, moving forward, make better policy, make more targeted responses? So in terms of housing, let me move this up here. So the data shows that poverty, overcrowded housing connected to COVID-19, rates among racial minorities in Toronto. So everyone's covered, right? This is the Globe and Mail, the CBC, the Toronto Star. You read one article for today covering that. But this idea that we've had a housing crisis in Canada, we'll specifically look at Toronto. We looked at the numbers at the beginning of the course, that it's a 7 to 10 year wait list right now to get into Toronto community housing, so subsidized housing for folks. So we had this pre-existing housing crisis that folks were not housed in safe ways. So when we add COVID into the mix, things just become more dire for people who are not able to access safe housing. So if you have 8 people living in a 2-bedroom apartment and one person tests positive for COVID, how are you actually able to self-isolate? What could that actually look like? It's not going to be something that you can do in such a small space based on what we know about COVID and the way it spreads. So housing in the York University Heights area is not good, right, folks? There's a lot of folks living in overcrowded housing. We intersect that with poverty and what that all looks like. Large buildings having to take overcrowded elevators, having to wash clothing in communal spaces. Those are all risk factors for contracting COVID in this area. So if we think about this area of housing and intersections with poverty, it's going to determine community spread in terms of COVID, because people are not able to self-isolate. So all of the guidelines that public health puts out, which is, you know, if you test positive, you have to isolate for 14 days. How are you able to do that? I'll give an example of the way that Cuba responded to this. So Cuba set up right away large quarantine centers, and folks were quarantined in that center where they could control all of that. So instead of saying go home to a space where you may live with 7, 8, 9, 10 other people and try to isolate, Cuba said the way that we're actually going to do this is to create centers where people can then come and isolate in. So that's just an example of a way that you know, you can do this differently in ways that we didn't do this differently in Toronto. And that's why we're seeing COVID where we're seeing it. So that's the first area. Second area, social isolation. So where I want to tie this to is kind of in terms of racism. So the Black Creek Community Health Center, which is located in this neighborhood, put out a message around disrupting anti-Black racism. It says, you know, you can read this on their website. Recent months, weeks, and now days have been particularly difficult for many in our community. As we continue to deal with the new normal of the COVID-19 pandemic, we're becoming more aware of the intersectional impacts of this virus on those we serve. So really thinking about the ways that this area around York University has been living poverty in intersectional ways, in very deep ways, has been very much isolated in terms of supports, ways that we can serve communities in different ways. And so that has created very specific conditions where COVID has been lived out. So you can look up the Black Creek Community Health Center. I put just their opening video there that you can click on to learn more about them. You can go on and read their entire statement, the message on the community about anti-Black racism, but really thinking about ways that this community has particularly been living poverty in ways that then COVID is able to spread a lot easier. So you can go on and read more about that in terms of thinking about this area of social isolation. The next area, food access. So I've talked about them before. Black Creek Community Farm, just next door to York's campus, immediately mobilized at the beginning of COVID. So the director of Black Creek Community Farm has come and spoke to this course before, and really taking up this idea around what food access looks like in this neighborhood of York University Heights, of Jane Finch area, and ways that this has been a food desert. So there's a real lack of affordable fresh food in the area. So folks have been living dire circumstances around access to food before COVID. So Leticia Daewoo, who's the director of Black Creek Community Farm, instead of talking about a food desert, she uses the term food apartheid to really call attention to the government inaction around access to food, government inaction around responding to the fact that some neighborhoods and areas in Toronto are not able to access food for very specific ways that intersect with poverty, with race, with disability. And so thinking about this idea that if before COVID, there was an extreme problem with access to food in the area. Now with COVID, things have gotten even more dire. So Black Creek Community Farm, as I said, quickly mobilized they work with Food Share on Toronto in order to get emergency food boxes to families. So I've been tracking the stats from the beginning of how many people in the area, so the small area around York University, who have been accessing these emergency food boxes. So these are the updated, the latest stats we have is August 17th. They have served 15,528 individuals. They've delivered 9,875 boxes, and a box of food is essentially a box of fresh food that goes to a family and might, feed a family for a week in terms of fruits and veggies. Total pounds of food, 157,968. So as I said, they quickly mobilized, started getting these boxes together and ways that they could get the boxes to folks safely to their door. So you can see some more about the work in terms of what Black Creek Community Farm does. If you're in a position to donate, they are still accepting donations because this is ongoing, right? Folks are still experiencing emergency access to food. If you're someone that needs to access food, check them out. They also have a program for Black students at York University to access emergency food boxes. So you can go there and just read some more about it and think more about this idea of food access during COVID and what that looks like. So income and job security. So we talked a little bit about this at the beginning in terms of ways that what kind of job you're doing very much puts you in a position of whether you are more at risk for contracting COVID or not. So the area around York University has a high number of folks who are not able to access safe work or who are working 1, 2, 3 jobs. There's many temp agencies that work in the area. You might have heard of Fiera Foods before, who are a very unsafe employer that takes people, for the day, pays them by the day for work. So again, there has been a long history in this area of not having access to safe work, and COVID has only intensified that. So again, this idea, if you're unable to take time off to self-isolate, paid time off to self-isolate, what does that look like? You may lose your job. What will that look like for your family? The plunge into poverty has been very much deepened by COVID. In terms of, what kind of job you have, if you were able to immediately work from home and kind of, stay safe and isolate versus having to travel to 2 or 3 jobs, having to be an essential frontline worker in care homes, spaces that we know had very high transmission rates of COVID. So all of that exists in this area. These are all jobs that folks are doing. So all that frontline stuff of working in grocery stores, meat, which of course then puts your rate up of your chances of getting COVID because you're in many different spaces instead of just one space. There's a tweet here. For the first time, StatsCan has provided race-based data on jobs in COVID. And again, it's telling us a very specific story at the intersection of race. So nationwide, unemployment rate was 10.9% in July, which we know is extremely high. But for Black Canadians, that number was 16.8%. That's massive. That discrepancy there is huge, and that's telling us something. For South Asian Canadians, it was 17.8%. The unemployment rate for South Asian women was a remarkable 20.4%. So that's double what the nationwide unemployment rate is. So what this kind of disaggregated data based on race allows us to do is allows us to see where COVID is impacting. And then we could make policies that specifically looked at that area. So what's happening with South Asian women in unemployment? Why is that happening? Where are South Asian women employed that employment rate is skyrocketing? So this is the kind of thing we can do with disaggregated data. So yeah, I want you to think about that. Are you employed? Were you employed before COVID? What has that looked like in your life? What has changed in terms of that area for you? We can look at it in so many different ways. Transportation. So I don't know if any of you live in the area and have taken transportation in the area, but many parts of Toronto, buses and subways are running completely empty. That has not been the case in this area. So this 35 Jane Street bus, I drive through all the time, the intersection of Jane and Wilson, and the buses there, huge groups of people having to wait and exit and enter at the same time, which we know those are all places where transmission can happen. So this piece around transportation is huge. I threw up a link here, a great article done on The Local, summer 2020, not summer 2002. What a bus route reveals about race, class, and social vulnerability during a pandemic. So again, bringing these intersections to bear on the area of transportation and what that looks like. If you're taking transportation to 2 or 3 jobs, and you're having to do that on TTC, it looks very different than you, say, going out once every 2 weeks in your car to do a grocery run. So this area of transportation in this specific area has been lived in a very different way than it's been lived in other ways. And that has impacts on transmission rates. Language and culture. So I want to depart a little bit from the area of sort of Jane Finch, York University Heights, and just think about this a little bit in terms of, so we think about this idea of culture and language and how that determines whether you are at more risk for COVID. So, there's lots of things that public health has been able to do. So they've translated public health messaging into many different languages and gotten that out through grassroots organizations, through NGOs, through clinics, through people who serve those who live in these areas. So that's one thing that public health has been able to do, right? So do translations, make sure that we're getting information out in culturally sensitive ways. So here is a poster that they did in Eastern Ojibwe talking about hand washing. So I want us to think about that in relationship or in intersection with the social isolation piece. So last week news came out that the Neskantaga First Nation, which is pictured in this picture here on the screen, so very isolated First Nation community. Hundreds have been evacuated as a new water crisis hits the community. So this community has had the country's longest boil water advisory. If you're not from Canada or not familiar with what that means, I urge you to do some more research. There are many First Nations communities across Canada who live under boil water advisories because the water is not safe to drink. So I want to think about these two things in relationship. So here we have public health doing work around translating how we need to stay safe from COVID. One of the things we know we need to do is wash our hands and stay clean in those ways in order to make sure the virus is not coming into our homes. How do you do that in a community where you don't actually have access to safe water? This is a crisis in many First Nations communities in Canada. So if we do that intersection of race and COVID, we see it's being lived very differently based on historical injustices and inequities around water, around land, around health, around access to things which are human rights that we all need to live. So, we can do certain things now under COVID, right? So translate public health language. But what does that mean in a community that actually cannot access safe water? And folks, the chief of the First Nation had to push so hard in order to get elders, children, those who are immune compromised, actually evacuated from their community because they don't have access to safe water in 2020 in Canada. A couple of years ago at Ryerson, because there was a really interesting kind of art activism installation on the Ryerson University campus. So they had all of the boil water advisories for each First Nation in Canada sort of printed on signs, and then they put those signs all across one area on campus. And so it was written the First Nation, the name of the nation, the boil water advisory, and then the dates for when that advisory started and whether it's ongoing or not. And it was such a striking way to understand this issue, to see how many of those signs existed. The timelines were so disturbing for, how many decades some communities have lived with boil water advisories. So yeah, if you don't know about this, I urge you to kind of do some more research and just do some more reading about what this looks like today in 2020 here in Canada. So this piece that we've never been all in this together. So we really do see this clearly when we use intersectionality as a tool, right? So last week, that's what we really talked about, is how we can actually use intersectionality as a tool in terms of intervening into health inequity. So when we look at this experience in a specific time and space of COVID, and we use intersectionality as a framework for us to understand this, we can really see who is bearing the brunt of COVID and who isn't, and how that intersects with race, with class, with disability. So when we disaggregate the data and we actually look at where COVID's being lived, we can then respond in different ways. So when we ask those in communities that have been marginalized by policy, by inaction, for many, many years, of course, before COVID, communities that experience high levels of poverty. So when we look at the data and say, okay, we know that this area is experiencing much higher transmission rates of COVID for these reasons, and then we ask folks in those communities living the brunt of this pandemic what they need, we could make very different policy decisions. We could make very different responses that are determined by those who live in the community, those who serve the community, those who understand the community, and based on real data, right? If we don't collect this data in terms of race, in terms of disability, in terms of all those intersections, we then cannot actually respond in ways that are going to work, right? So that's something we've been talking about throughout this course, is unless we have a real understanding, so that can be done through data that's disaggregated, but it has to be in relationship with some qualitative data where folks themselves are saying, this is what we're living and this is what we need, which are things that intersectionality asks us to do, right? So this today is real thinking the way intersectionality can get us to different points in our analysis and different points in our response, and who needs to be there shaping those policies, right? So last week we took up a picture of Doug Ford's cabinet and who they look like. Are they the ones living the brunt of this pandemic? In their communities? No, they're not, right? And so if we have folks from communities having real input into policy, policies will look different. So I wanted to stop and just, have you think a little bit about your thoughts and reactions to this. What are you thinking about in terms of using intersectionality and how useful it can be? Sometimes we see intersectionality as this kind of big, intimidating theory, but if we think about it as just a real tool to allow us to intervene in an inequity, it's easier for us to engage with it. So here's some big data from the Broadbent Institute. I just wanted to pull this up, and it's they asked the question, what do people want to see in kind of a post-COVID or even a with COVID moving forward Canada? So you can see here what people are saying, right? So extremely important is on that far left and not important is on that far right. So we can see, one of the biggest asks are around investing in our health system, including universal public pharmacare, and then increase tax or create new taxes on Canada's richest people. Those are where the most people said it was the most extreme importance to them. So where do you sit? Where are you sitting on this? Thinking about ways we need to intervene, ways we need to move forward. Are these things that are also important to you, or are you sitting somewhere else on that chart? And then thinking about how that looks in relationship to where you sit on that wheel of power, what intersections you sit at. So I think this kind of data is obviously very interesting, but I think it would be more interesting if we knew it disaggregated based on things like race, class, gender. And we'd be able to see a very different picture based on who's living the brunt of the pandemic and determining ways forward versus who's not living the brunt of the pandemic and ways they imagine forward. And of course, those are going to look similar and different and, depart, but are there any sort of broad pieces or asks that we can see that are very striking, right? So a couple of weeks ago, we pulled up the data and disaggregated it based on who voted for Trump. And so we saw a large number of women voted for Trump, but then when we actually looked at who those women are based on race, we saw a very different picture. So it would be interesting when we do this kind of data collection and asking folks where they want to see change. If we did that, and asked about demographics and then disaggregated it, we could see very different pictures on what folks are asking for. So they did an interesting survey a couple of months ago in terms of university workers, so profs, those in admin positions, staff positions at the university, in terms of how it's impacting them. And it was very interesting to see the results on, very much there's lots of impacts on ways that people have lots of care in their lives and how that's impacted the way they work in the university and all those kinds of things. But it wasn't disaggregated. And so we weren't able to see who is living the pandemic in very specific ways in the university, right? So if it was disaggregated based on gender, based on race, based on disability, we might start to see very different pictures on who's being impacted, whose work's being impacted by COVID in the university. So yeah, I think it's just an exercise that you can go through yourself. So you could pause and go through this. So we'll put a pin in this, but we'll kind of come back to this. So in week 11, we're going to take up at the end of the course, doing health access differently. And we'll come back to this kind of discussion just around what would it look like if we disaggregated data? What would it look like if we thought about intersectionality as we were asking questions around COVID, but just around health inequity in general. So we'll put a pin in this discussion and come back to it in week 11. Obviously COVID, because of the ways that we are now much more at home, there's one of the positives have been there's a lot more access to interesting speakers, information that we might not have been physically able to get to for many different reasons, right? You could think about access in many different ways. And so there has been lots of very, very interesting town halls, discussions that are now much more widely available. So there's a great town hall, Rising Up During COVID-19, Solidarity, Anti-Black Racism and Health, that came out of U of T, that brought together some huge kind of people thinking in this area. So Olivia Chow, politician Paul Taylor, who is the director of Food Share Toronto, Cheryl Prescott, who is the director of the Black Creek Community Health clinic that I put up earlier, Kathy Lewis and Dr. Norum. So if you want to take some time today or another day to click on and watch this town hall, it captures a lot of what we talked about today and goes a lot further. So they're real experts in the fields of community health, anti-Black racism, and thinking about ways we can respond to COVID with this lens of solidarity. So really this lens of intersectionality, right? Intersectionality takes up allyship, solidarity, in very interesting ways. So I urge you, if you have time or space for this, to engage further, especially if you're thinking about writing in this area for your paper for this course or your writing assignment. This would be a good resource to go to. And I put the link up there. So I wanted to take up, we're going to move a little bit now and take up these approaches to health equity. So one of the readings that you did for today was this approaches to health equity reading that you did. So talking about the ways that we can approach how we build more health equity. So this is going to be a piece that you're going to explore in depth when you do that major writing assignment. So I wanted to take them up today, start to think about them, and this is going to be something that you're going to actually do when you get to the major writing assignment. So you're going to think about these approaches and ways that you are going to advocate for some kind of approach or intervention. So we're going to take them up today, and then you're going to go more in depth with it when you write your assignment. So they take up a few different approaches to health equity. What are ways that we can build health equity? What are major approaches to health? And we know that these are reflected in various ways, right? Like these aren't mutually exclusive. Different approaches exist alongside each other, but kind of broadly, what do different countries, different states take up in terms of their approach to health equity? So the first one, we know well here in Canada because it's our approach, the universal approach to health. So basically this universal approach says that everyone should have the same access, right? So it's a system that's built saying at the heart of this is the idea that everyone should have the same access to health. So an example is our universal healthcare system. So essentially, as we know, everyone is entitled to a basic level of care that is completely regardless of employment status, gender, age, income, disability, race. All of those things are not to come into play. Of course, we know in reality they do. But when we build a universal healthcare system, we build it with this underlying idea that that's what we want to do. Whether it can meet its goals is a different story, but this is what a universal approach would lay out. So what are some challenges with building a universal approach? We basically just said it, right? That a universal approach can be created in principle, but it's not actually lived out because humans who are doing the work of ensuring universality are steeped in systems of racism, of ableism, of sexism, of transphobia, all of those isms that live inside of people's bodies and enact them, and mirror the larger societal sort of injustices and systemic oppression. So the major challenge really is that it's a beautiful idea, but how it actually happens in person doesn't always live up to the idea. The universal system also has the danger of compounding privilege. So because everyone has access to the system, it can just compound privilege for those who already hold it. So those who already hold privilege get more privilege in a universal system, right? Because they have access to things in very easy ways. And so it sort of compounds privilege. It allows those who already have access to have more access or enjoy their access in deeper ways. So that's the challenge when we're kind of creating this kind of system. And we need to be aware of those as we think about ways forward. Targeted approach to health equity is another way that some states take up to intervene. So basically, a target approach applies to a subgroup within a defined population. So it's a very specific intervention into inequity. So an example would be a food security program that only exists in a community which experiences food insecurity or is a food desert. So instead of saying everyone has the same access, it's saying this particular community lives something very specific, so we will make a targeted program or approach in this area. So a food security program, for example. So saying, this area doesn't have access to good, fresh food, so let's create a program that only those who live within this area can access in order to kind of, move towards equity. So some challenges. This can really address the consequence of inequity and not the cause. So we've talked about that throughout this course, right? These kind of symptoms and not the underlying causes. So that's what this can do. So, it's sort of a Band-Aid. It can be a Band-Aid solution. So instead of saying, there's some deep-rooted issues around food security, we just address it in this one area. It can do things like targeting lifestyle behavior changes and not structures. So it can, there can be a targeted approach, might be giving people education on ways that they can prepare healthy foods instead of, which is a symptom, or a behavioral change, instead of saying there's some deep-seated larger structural problems, which is food is actually just unaffordable fresh food in this area. It's not about folks not wanting to cook it or not knowing how to cook it. It's about the idea that if you're working 3 jobs at minimum wage and have no time to prepare food and have no time to, access and no resources to access that food with, that's a larger structural problem that needs to be met at a different level, which is, universal basic income, or, access to a living wage. Another challenge is data collection can be time consuming around this. So it's going to take many years to figure out whether this target approach is actually working. If we take intersectionality into account, who is it working for? How is it working for specific populations? So it's difficult to measure how this is working. It would take a long time to measure. Problems with execution could be that it's kind of, when you're creating a targeted approach, it might be too expansive. So it might meet everyone in an area, and some folks actually don't need that targeted approach, right? Because, based on income or based on other factors. So it's kind of hard to actually execute a targeted approach, because you either may have it too expansive, so it's really expensive to run, or you might have it too rigid, and so folks aren't able to access who need to. So kind of coming up with the logistics of a targeted approach can be very difficult. So those are some challenges to intervening in inequity by using a targeted approach. And then we've got kind of blended approaches. So that's kind of, the best of both worlds. What it looks like if we blend the 2 approaches together. So targeted universalism is a blended approach that basically, when we have universalism, it can still result in an unacceptable health gap, which we have, right? We know we have that in Canada. And that a targeted approach can have little effect on the slope of the health gradient. So a targeted approach isn't making enough intervention fast enough, effectively enough, that it's actually getting at these health gaps. So basically, targeted universalism is this idea that we have this universal system, but then, so it has these defined goals for all, which is, everyone should have access. But it also, at the same time, identifies these obstacles that are faced by specific groups, and then makes strategies that would really address these barriers in those specific situations. So I really do sort of hear echoes of intersectionality here, right? So if we have this universal system, okay, everyone can access it, And then getting at that problem of compounding privilege, which we identified in the first slide, we then have targeted approaches that sit within universalism, right? So as I mentioned with COVID, this is what many community health clinics are asking for. They're saying, okay, we need to have targeted approaches in these areas that are experiencing COVID in disproportionate ways in order to actually get at the population that's living the brunt of COVID. The article also brings up proportional universalism, which we won't get into because it's basically more popular in the UK and Europe, and we're not going to worry about that. So think about the three approaches, really. So tying a little bit these interventions to the rights approach and intersectionality. So what does that kind of look like? So thinking about these interventions in communication with intersectionality and a rights-based approach. So your access to the right to health depends on many different factors. We know that, right? We just did an entire lecture on that, thinking about what that looks like in terms of COVID. Rights are not automatic, nor are they universally enjoyed. Just because we say everyone has human rights doesn't mean that that's happening in practice. Targeted universalism can help realize rights for marginalized groups, right? We know that it can work. If we do targeted universalism well, it could be a good approach to meet the challenges of universalism. So thinking about intersectionality there, right? And who needs to, how do we plot out the targeted universalism interventions based like through an intersectional lens? We know that rights, many levels are granted or not granted at a micro level. So many of you mentioned that specifically in your critical reflection paper, that ways that you were received in the healthcare system, your right to health was determined by which doctor you saw. Maybe you first saw one doctor and they didn't take your symptoms seriously, and then you saw another doctor and they did, and that determined your access, your right to healthcare. And then you saw that through intersections of race, class, gender. So rights really happen at this macro level. They don't live outside in this cloud somewhere. They happen through individual interactions. You can come back and look at this video. It's the Sherborne Health Bus. So they work with folks who are street involved in a specific area of Toronto. And I really want us to think about this as an interesting targeted approach. So they have a bus and it actually goes out, meets folks where they're at, and they talk about all these intersections, right? Of like poverty, disability, class, race, what that looks like, and how folks at those intersections actually cannot access frontline healthcare. It's not safe. They might not have documentation because they are street involved, and it's very difficult to get a health card when you live precariously like that. So a group of street health nurses came together. There's all kinds of organizations involved in this project of the Sherborne Health Bus, which actually just brings frontline healthcare to folks where they're at. They do trauma-informed care. They talk about ways that you meet folks where they're at in order to actually care for them. So I want us to think about this as a real tangible example, as a universal targeted approach, meeting a very specific group of people. Coming back to COVID, I want us to think about this idea of organizations asking for targeted approaches. Our medical officer of health, Dr. Eileen Davila, also talked about this idea that we need targeted testing in areas where COVID is higher. We need, she says it, right? Where COVID-19 is hitting hardest, tailored, targeted action is needed. So of course, it's still universal. Everyone is still having the same access, but then we do very specific targeted programming around testing for COVID in areas. So Black Creek Community Health Clinic's doing that, and they move around. Different health clinics in Toronto are doing it. So if you need to get tested, look this up. They'll do pop-up testing in the communities that are experiencing it. So right here, the picture with the white car in the background, they were doing a test at over at Downsview in that big building where the flea market is. So you could just come by, no cost, and get tested. So bringing testing to where folks are instead of expecting folks to get in a 5-hour lineup somewhere where they don't live, when they actually cannot do that because of the different social determinants in their life. So that's a very tangible example, right, of this, this approach. So I'm just a reminder, as we're moving, we're in week 6. Week 9 coming up is the writing assignment that's going to have to do with these approaches. So you can read more about it here. I'm not going to read it out, but basically, so it's on your radar. You're going to be looking at a health on the front lines kind of issue, and then taking up intersectionality, and then using that reading on targeted and universal approaches, designing something. Right. So we just saw what Black Creek Community Health Clinic designed. They were like, okay, our community is living the brunt of this pandemic. We need testing in our community. Let's have pop-up testing. Let's have no barriers for folks. Right. So it's due week 9. It's going to be 4 to 5 pages, 4 to 5 academic references, and then you can build around that other references. So if you want to use, different community stuff, gray literature, reports, all those things around it. I just wanted to pull this up. It might be interesting for folks, this idea around impacts of COVID-19 on mental health of Canadians. So there's some data that's coming out here that's telling us that because folks aren't able to get to counseling, psychotherapy, that folks are using prescription medication. 1/2 of all people who accessed mental health services before the pandemic are no longer accessing because of a reduction in access. So the very time that folks are living very dire, extreme circumstances, we have less access to mental health supports. What is that going to look like in the future? And if we think about that at the intersection, so again, think about if we disaggregated this data on who is living this, who's not having access, who is, and who's living the brunt of the pandemic, who needs that access, we could paint very different pictures and understand things in different ways. And then responses could look different. So you can click there. There's the link for the study. So we are moving on to our next module. So today we've kind of started that, thinking about module 3. And so I just wanted to give a little bit of kind of understanding that you're going to take into this next module. So we're going to be taking up kind of specific areas or intersections, complications around sort of complicating around access to health in different ways. And so we're going to be taking up racial justice, disability justice, food justice, Indigenous ontologies and responses to wellness. And so these are all areas that are going to give you lots of ways to think about that major assignment and what you want to write about and think about. And so each week has kind of one reading that you're to do, and then lots of, a few readings around COVID. So I don't want you to feel overwhelmed by the amount of readings each week. You can kind of go through those as you're able to. Maybe you want to write your paper in a specific area, so you really want to focus on that week. And the other week you do less reading. You kind of skim over, you engage with it a bit, you engage more with the lecture. So really, I don't want you to be overwhelmed moving forward. Really, this is to say these are these very we're going to take up these intersections in very much more complicated and deeper ways each week, and that you can then engage more deeply with the week that you are thinking about in terms of, maybe your own work, your own identity. You're writing that major assignment. So don't feel overwhelmed by it. Engage to the extent you can that week. If the week is overwhelming to you, and you've got a lot going on, then maybe focus on another week. If that's the week you want to write on, more intensely focus on that week. So I just want to give an invitation to you to not feel that you have to do everything in each week. It's more me trying to give you a robust understanding each week. And then as you're able to, you engage on what level you can each week. I hope that makes sense. So next week, we're going to take up racial justice, week 7. So again, you'll have your readings are going to be one report to do to kind of think about this intersection of race and health. And then there's going to be the pieces around COVID. So there's 2 news articles, and then there's the full study that you can read. So again, it's kind of this, do what you can, read as deeply as you can. We're going to have our first guest lecture. So we have a really interesting guest lecture talking about intersections between race, defunding the police, getting cops out of schools, lots of grassroots work on what that looks like and ties to mental health, and then how that impacts health, right? We know that through Timothy's reading. So next week we'll have an interesting guest lecture. There are your readings. Just a reminder that your academic skills assignment is due Friday, November 6th. I'll keep sending out updates with reminders for folks. I hope those are helpful. I hope you have a good rest of the week. It looks kind of cold and rainy here in Toronto, so I hope there's times where you can get outside and get some fresh air, because I think we all need that as we're sitting so much at the computer. Have a wonderful week, and I will see you next week, week 7.